Good afternoon, everyone. I'm Douglas Terran, an Associate Dean in the College of Public Health. Some people may be showing up later because this is somewhat a hard room to find if you don't know the numbering system in this college building. It's my pleasure to introduce Teresita Gonzalez de Cosio as our speaker at a special seminar for the College of Public Health. Terry got her PhD at Cornell University when I was a student there with her. And then she, I think, she was at INCAP. You worked at INCAP too, which is the Institute for Nutrition Central America in Panama, and which has amazing studies about growth and infant health over time. And then now she's at the National Institute of Public Health and is the director of their PhD program in nutrition also at the School of Public Health there, which is a school where you would, if you were at Dr. Rivera's lecture yesterday, a school that's so intimately connected to the government that they can really disseminate information very quickly. So this idea of innovation and dissemination, it really happens at their institute. And there's only a few schools like that, I think, in the world. I think of Mahidol University in Thailand, that is similar, where they're almost part of the government at the same time. And Terry's work has always been around, as far as I've known, around maternal and child health. And she is someone who has, when I was in Mexico the last time, and maybe the time before, is when she was being inducted in the National Academy of Sciences in Mexico. And I remember Juan was saying, do you want to drive all the way to Mexico City from Cuernavaca, which isn't much of it, like an hour drive, but I remember that. So it was really, I'm sorry I missed the ceremony, but that was, it's like being in the Institute of Medicine, right, in the US. And so Terry's going to talk to us about the things that are happening in Mexico around breastfeeding and issues of breastfeeding itself, not just the promotion of breastfeeding, but some of the physiological issues we have to consider about breastfeeding. And so it can be promoted in a very correct way. And I'm not sure if you're going to talk about what happened in Mexico City at all. Yes, I will. Okay, so there's a whole issue. If you ever learn about the Breastfeeding Promotion program in Mexico City last year, that was very controversial. And I'll let Terry, I won't take her storm away, so you can talk to us about that.
Thank you. Thank you very much. I don't know if this is the microphone that I should be using, because I also have this one here.
She has a lavalier on.
Oh, so you're fine with this?
With
your, you have your
but
mic.
for the audience, right here.
Oh, they can hear you, I'm sure.
Okay. Well, good afternoon. Thank you, all of you, for being here. It's really been a great pleasure to be at U of A. I thought it was going to be a great pleasure because I know Doug and we've been good friends and we've been on and off doing things together. But it's immensely I underestimated immensely the pleasure that I was going to have here. Because there are so many, I shouldn't say so many common things that we have because there are so many Mexicans here that it would be not good news, not news. But there are so many interesting things that are interesting to you and that are also interesting to us, and so many opportunities to collaborate that I'm really thrilled that this is happening. And I really want to thank Dr. Tarrant for this invitation. As Dr. Tarrant said, I'm presenting breastfeeding and infant health, especially with regards to common issues that are occurring in Mexico. And although I'm presenting, I want you to know that I have a very nice group of researchers collaborating with me. Dinora González, Leticia Escobar, Arancha Colchero, y David Contreras. And Juan said yesterday that we are the city of the eternal spring. And this is just a picture to let you know that jacarandas are blooming now in Cuernavaca. So if you'd like to come, I'm sure one of the things that you will very much enjoy are the flowers. What I want to present to you today is the things that I have in this outline. First, I always like to start saying what are the WHO recommendations for infant feeding practices. And although everybody knows them, repetition is the master of doing things correctly. So I always want to go through those again. And then I would like to talk a little bit about human milk, because human milk has been mistakenly labeled as a food. And human milk is really a system, and we're going to talk about that. And then I'm going to talk about breastfeeding practices in Mexico, data from our national health and nutrition surveys. I'm going to let you know about some of the studies that we've conducted. How much does it cost us in terms of morbidity, mortality, and dollars of inadequate breastfeeding children, infants in Mexico? And then pointing out public policy recommendations that UNICEF and WHO have described perfectly well for the countries, what we need to do to improve breastfeeding practices, to tackle the problems associated with it, and what have we been doing at INSP. INSP is the acronym for the National Institute of Public Health, in Spanish, Instituto Nacional de Salud Pública, and I'm sorry if I'm going to refer to it as INSP because that's just the way I know it. And then I'm going to finish with some conclusions. So you know that WHO recommends exclusive breastfeeding for less than 6 months, and then continued breastfeeding for 2 years. And if I had my way, I would start saying breastfeeding for 2 years and then exclusive breastfeeding for 6 months, because the message often when you start exclusive breastfeeding for 6 months, the attention span that we humans have, it's rather short. So recommendations, it's exclusive breastfeeding for less than 6 months, and that's it. Then we start thinking something else. And that turns into a promotion of breastfeeding for 6 months. And that's a very serious problem all over the world, especially in Mexico. So it's continued breastfeeding for 2 months. And also, I'm not talking about it, almost nothing. I'm going to show you some data, but almost nothing relative to the timely introduction of complementary feeding, which should be dense in nutrients, culturally adequate, and safe to consume. And this is particularly important. Infant feeding practices are particularly important because there's an enormous plasticity that we have for the first 1,000 years of our existence, 1,000 days of our existence, which are the conception and the first 2 years of life. And during that time, we can become almost anything in the human possibilities, and all the potentials are written, almost all the potentials are written then. And whatever happens has the potential to modify the outcomes in terms of health, psychological intelligence, and immunity. So if we focus, excuse me, if we focus in this first 1,000 days, we have the potential to do enormous benefits to the infant. I'm sorry. No la traje. I said I was going to talk about the system of human milk, because human milk is like it's like the blood that the mother offers the baby during pregnancy. This continues somehow during lactation, and it's a system that has taken thousands of years to develop. And it has been developed so as to optimize health and survival. It has, of course, it has vitamins and minerals and proteins and water, but it also has very sophisticated system. For example, fat is delivered to the milk stream by apocrine. That it means that the cell breaks itself, the cell membrane breaks itself, envelops the fat globule, and delivers it to the baby. And within that membrane, a lot of information about immunity, and it's delivered. So we can go on and on. We have oligosaccharides that are, it's a very abundant carbohydrate that is not to be used as a carbohydrate. It's a substance to be used to defend the infant against bacteria and against pathogen agents. We have also, human milk has stem cells. This is very new, and I was really impressed by it. It has stem cells, so that cells from the mother that are delivered to to the baby can become brain cells or heart cells or kidney cells. Of course, it has immunological factors, and it has several hormones, not only prolactin and oxytocin, but it also has insulin growth factor, it has insulin, and several other hormones, many of which we don't know what they are for. So this is to say formula is not a good substitute for this, because formula is a food, and human milk also has not only all these components, but it has a flavor and it has an odor. So the infant that it's breastfed has a better capacity to accept other foods than the infants who have been fed formula that only know one flavor and one odor, and also miss all this. So what's the benefit of being breastfed? There are benefits for the child, for the mother, and also for the economy of the family and of the country. And I'm going to show you some data about it. But in terms of just a brief review, children who are breastfed, according to WHO recommendations, have improved survival. They die less. It's not that they don't get sick. They get sick, but when they get sick less severely. And also they experience less infant death syndrome, sudden infant death, which is a terrible death that mothers and fathers go and pick up their baby, and with no reason the baby is dead. And it's very much related to breastfeeding. But also decreases the incidence and severity of those illnesses that are killing babies. Not only the regular illnesses of diarrhea and respiratory infections, but also pneumonia and necrotizing enterocolitis, leukemia. It's very a good protector for these diseases. It also strengthens the relationship between the mother. It's not that mothers who formula feed their babies cannot establish a relationship, not at all. But mothers who breastfeed are in tune. They have to be looking at the baby and responding to at least to the position of the nipple in the baby. And so that makes fosters a relationship between them, between the pair. Maternal health is also improved. Mothers have a lower incidence of breast cancer and also of ovarian cancer. Breastfeeding, it doesn't really help you to lose weight, but at least it prevents the weight from increasing, as it does for postpartum women that tend to increase we tend to increase our weight during the whole life, and reproductive cycles even more so. So breastfeeding favors this stabilization of weight. Mothers who breastfeed also experience lower incidence of diabetes, type 2 diabetes, especially those mothers who had a history of diabetes during gestation. And early weaning and not breastfeeding has been related to this this increasingly high incidence of mental health, which is depression. And it's not that mothers who breastfeed do not get depressed. They do, because it's a complicated situation for the mother to have a new baby and then to have to feed the baby and be responsible for the baby completely. But depression is less likely if she is breastfeeding. And then I'm going to show you some data. I'm going to take a few minutes in the future slides to show you what it means in terms of savings, that these benefits in terms of savings. But before that, let me give you the Mexican case. We conduct national health and nutrition surveys every so often. We conducted the first two that were nutrition surveys in '88, in '99, and then 2006 and 2012 we conducted national health and nutrition surveys. So I'm going to show you data from the '99 survey, which was the first who contained breastfeeding practices, up until our last survey. These are surveys who are nationally representative and are representative also at the state level, and all three have similar methodologies. So it's very good because you can compare them, and we collect data on anthropometry and diet and health. And for breastfeeding, I don't know if you can see very well these graphs, but what I'm presenting you here is several pieces of information. Here, this is a graph that has the percentage of different kinds of breastfeeding that I'll describe in a few seconds, and this is the age of the child. So these solid lines represent exclusive breastfeeding, and the dotted lines represent any type of breastfeeding. And if we follow WHO recommendations, we would find these solid lines up to here, and then all of a sudden drop to 0, exclusive breastfeeding at 6 months. But all the rest of the children would be continuing breastfeeding for 24 months or more. But we don't see that in Mexico. We see a very different picture for what it's recommended. For exclusive breastfeeding, it's particularly worrisome. I'm sorry. We begin with less than half of the infant exclusively breastfed at birth, and it drops very fast during the first 6 months. And any type of breastfeeding it's around 90%, and it decreases also rapidly, but not as much as exclusive breastfeeding. So that, for example, the median duration of breastfeeding, of 50%, the point at which 50% of the mothers are still breastfeeding, has not moved since '99. You can see it's around 10 months. We have the median duration of breastfeeding is 10 months. What has declined is exclusive breastfeeding, and these 3 lines represent the blue one, the 99, the red one, the 2006, and the blue one, the 2012. So it cannot be perceived very clearly in exclusive breastfeeding, but it can be perceived in the duration of breastfeeding. But the next graph has a clearer picture of what has going on through time. Again, this is 99, 2006, and 2012 data. And we have here the indicators that WHO recommend we collect. So we use the methodology of the World Health Organization, and you can see the first indicator that we have here is percentage of infants less than 24 months of age that have been ever breastfed. And you can see that it's a very, very high percentage. It's 93, 94%. And then it drops very much. And at exclusive breastfeeding at 6 months, it's now 14. It decreased from 22% to 14% from 2006 to 2012. That's a dramatic decrease, and it's explained by increasing the consumption of formula and also the consumption of water and other liquids. Not everything is as catastrophic as exclusive breastfeeding. We see that the consumption of iron-rich foods and the timely introduction of solid foods, complementary feeding, have been improving through time. But we also know that what's most related to survival is exclusive breastfeeding under 6 months of age, and 6 months of age, yes, and that has been decreasing. And it's not that everybody else is doing the same. We are a very sad case in this matter, because I'm presenting data from Chesa Lutter from PAHO, if any of you know her. She's also a colleague of us. And she did a study on the duration of breastfeeding in different countries in Latin America. And you can see the red line is the measure, the duration of breastfeeding in Mexico in 2000. It's been like that. But you see that other countries, most of the countries, are above the point that we are, or improving. And only Dominican Republic has lower data than we have, at lower prevalences, which is really a poor case of poor breastfeeding practices. But in the continent, we are the country that has the lowest, sadly, the lowest duration of breastfeeding. And to understand what does it mean for us to have inadequate practices of breastfeeding, it would be necessary to cost all those benefits that we observed. And we observed that there are benefits for the for the child, not only for the infant below 1 year of age, but also for infants older. You know, I talked about leukemia and diabetes and obesity for the child. And also there are benefits for the mother. And what I'm going to present to you, it's a gross underestimation of the cost, because we're only costing a pediatric cost, that is everything that's happening below 1 year of age. I'm sorry. And we are not taking into account chronic diseases and nothing after 1 year, and we're not costing anything from the mother. We are a research group working with some econometric people. We are costing these other parts. So I'm only going to show you what's costing us not breastfeeding adequately for infants. And the objective of the study was to estimate the pediatric cost of 5 diseases. Thank you very much. For the 4 most common infectious diseases that we have in Mexico, and for which we have a monitoring system to collect data for, which is acute upper respiratory infection, lower respiratory diseases that are those with pneumonia who really kill babies, otitis media, and gastroenteritis. And we also did sensitivity analysis conducted to estimate the uncertainty around the registration of the cases, because we have underestimation on the monitoring of the cases, and also data on necrotizing enterocolitis and sudden infant death syndrome, for which we do not have good information in Mexico. So we analyzed other countries with similar situations and similar health systems than Mexico, and we conducted its sensitivity analysis. So the results that I'm going to present to you contain 2 pieces of information. The first one is those that we estimated given the data that we have in Mexico. And the second piece of information is the costs that, the expected costs given and estimating the underreporting that we have. So if we say we think that during this epidemiological and econometric analysis, we came out with a number that we are underestimating this disease or that disease 10 or 50 or 100%, then we are estimating those expected cases and the costs associated with those expected cases. Thank you very much. We calculated age-specific morbidity incidence and lethality. We had information on the number of breastfeeding infants on different categories, on exclusive breastfeeding, partial breastfeeding, and formula feeding, exclusive formula feeding. And this is really new because other studies have been published doing similar calculations, but have not had this categorization of the breastfeeding pattern. We estimated the number of cases adapting what everybody else used, this Weimer and Bartik and Reinhold model to estimate them. We used odds of the disease published from meta-analysis and disaggregated the meta-analysis to include only with the largest validity. And we estimated the health costs by cases and costs, direct and indirect costs. So for example, there's studies in Mexico that map all the procedures and activity related to every disease. So health insurances have this type of data. So we use that data for every case. And we also estimated fixed and variable costs relative to taking care of a particular disease. We also estimated the costs of purchasing formula and the loss of productivity due to premature deaths. So the results I'm going to present in these 2 graphs, okay? Tables. So this first table is the estimated annual number of cases and deaths due to inadequate breastfeeding practices in infants in Mexico. So in the first column we have the outcomes that we studied: upper and lower respiratory infections, otitis media, gastroenteritis, necrotizing enterocolitis, and sudden infant death syndrome. And these are the cases reported and expected. This is the sensitivity analysis. So for example, let me go through a couple of lines. Upper respiratory infection, we have fairly good registration for upper respiratory infection because moms take their infants to the health system for a diarrhea. So we have in a year around 100 cases of diarrhea for children up to 1 year of age, and the estimated incidence is just a little bit above it. Okay, and so given the lethality of gastroenteritis, we expect that related to inadequate breastfeeding practice, this is everything related to inadequate breastfeeding practice. These are not the total amount of deaths or cases in the country, just those that are accounted for by inadequate breastfeeding practices. We could estimate that it was 100, where's my arrow here, 159 deaths by using the reported incidence, and or 182 deaths if we use the sensitivity analysis for the incidence. So this table has the same pattern of information for all these 6 diseases, and we see that there are 3.7 million diseases that are caused by inadequate breastfeeding practices in Mexico, from which between 933 to 5,700 deaths in the country are related to these inadequate practices. And what is it costing us? We have here, again, the outcomes, and these are the direct costs of attending a child that is sick, and then these are the costs attributed to future earnings, that those who didn't make it, how much they would have contributed to the national economy had they not died. And this is also and we are, let me see if we, I'll have it in the next slide. So we estimate that the total cost of infections ran from $455 million to $2 billion just for pediatric costs. So in summary, if Mexico followed the breastfeeding recommendations, we would be saving approximately 5,007 lives and spending $2.5 billion less. And this gives us an amount of how much we would need to invest to improve breastfeeding practice, or shall we say the minimum that the government, the state should invest to improve practices in Mexico. And so we ask ourselves, who's responsible for this loss of breastfeeding, good breastfeeding? I mean, the usual suspects: health and sector, who should support better, or medical, nursing, or nutrition schools that do not teach enough breastfeeding and lactation concepts so as to make them able to protect and solve the problems that emerge, because there are always problems. Or is there lack of clear and complete legislation that protects the commercialization of formula, or has sites for women to breastfeed in their working in the employment place, not as a favor, but as a law, as a right? Or is it the industry that is uncontrolled and commercializes and promotes formula unethically? Or is it the lack of governmental leadership? Or is it just the mothers that they don't want to breastfeed? And I love this cartoon that I used from Dr. Ricardo Huawi, that has exactly the same concept, but in terms of obesity. So I borrowed it from Huawi and used it for lactation. So it is a maternal responsibility. I mean, it's a maternal decision ultimately to breastfeed, to put the baby to her breast. But in order for her to take that decision, many environmental and many factors, I'm going to show you exactly which factors have been shown to be supportive of breastfeeding, must be in her environment. Otherwise, the load of breastfeeding is very difficult for her if the environment is not favorable for her. If the laws are not there, if the sites to pump her milk is not there, if she doesn't have a person to help her with in the first few weeks of life, if she's not offered formula, etc. So it's a balance, and what we want to is to lower that slope so that it's easier for the mom. It becomes the healthy and the optimal and the easy choice. And WHO and UNICEF had put forth a very nice document, which is the Planning Guide for National Implementation of Global Strategy for Infant and Young Childhood Practices. It's from A to Z of who needs to do what to get our act together, okay? And it's really good. We don't have to make up or guess what needs to be done. It's laid down beautifully in this document. So that's our recommendations. So our recommendation is that, for example, the federal government takes the leadership. It has to be taking the leadership because of the way we have our health system. It's centralized, and it has to be taking the leadership to implement, to know this strategy and try to implement as much as possible the recommendations, but also to develop, implement, monitor, coordinate, evaluate, and fund and a strategy. We have to strengthen our breastfeeding baby-friendly and baby-friendly hospitals and health centers. We, there are some cash transfer programs to improve health that have proven to be useful in many instances in health. We should explore if that's helping for breastfeeding moms, to strengthen the monitor of the code, the International Code for Commercialization of Formula. We need to implement laws for favoring compliance, and we have to work in regulation. So who has to do it? The health professional, health associations, all of us, all who are in public health, but also, for example, National Academies of Medicine, pediatrics, gynecologists, everybody that would be related to breastfeeding should be ones who adopt a position about breastfeeding. And we need some responsibility. We have to assume responsibility to tackle the problem by its horns, as we say, and to have clear and simple and homogeneous messages. And it turns out that in Mexico, these messages would be the best. It's exclusive breastfeeding for 6 months and continue to 24 months. Not give water, because agüitas and calditos and very unnutritive and comforting foods and teas and broths are given to the baby erroneously. So the micronutrient density is very low in those. And it's very, very popular in Mexico and in Mexicans. So a message would be not to give agüitas or calditos, not to give anything, and then not to offer formula. And if the baby's hungry and if the baby's crying, well, there are ways in which lactation can be improved, and we should support it. So what have we done? This is a model I'm going to finish in the first few slides. Rafael Pérez Escamilla, he's a professor at Yale University, also a colleague from Cornell, and he has been very active in promoting and protecting breastfeeding, but also in studying public policy in terms of lactation and breastfeeding. And Pérez Escamilla and his colleagues conducted a very interesting study where they reviewed not only the literature that has been published, that's easy, but also what we call the gray literature, which is the documents that are produced by institutions that did not get published, like technical reports and things like that. So they made this great effort to review the literature and the gray literature of those breastfeeding promotion, protection, and supportive programs, and analyze what were the elements of those programs that made them successful. And under that, the underlying theory was a particular theory, social and a behavioral theory of how institutions and programs work. So it was there were layered two areas of information: what are the concepts, what are the things that work, and theoretical underlying concepts as to explain it and have it validity, scientific validity. So they came up with this very nice model, which is called breastfeeding gear model, pointing out what are the areas that must be present in a program so that breastfeeding is successful. So these are all very necessary. We all need it. It needs to be, all the pieces need to be present. So political will is needed. Legislation and policies should be there so that they can be enforced and protect. There should be funding for the resources needed to apply those teaching, those materials, those people that need to be there for the mom, those to develop those programs, etc. We need to have training and program delivery. Those programs, we need to teach health professionals all about breastfeeding and how to solve problems so that they can support mothers. We need to promote breastfeeding by ads and by mass media. And we need to do research evaluation so that we know what works and what doesn't work. Excuse me, we also need advocacy. We need groups to be fighting for the rights of breastfeeding babies and women. And at the center of it all, we need a leadership, okay? And in the case of several countries, this leadership must come from the government. And that has the points that I showed you before. Those, they should coordinate. There should be some penalties when things are not, when commitments are not met. And they should have a plan, an objective, etc. So this is really necessary, the coordinating goals. So I'm going to show you in the next few slides what has been done in Mexico, and mainly very much in work that we have conducted in INSP. So for example, in legislation, there has been legislation relative to breastfeeding to promote it. So the General Health Law in last year, it was modified. And if you modified La Ley General de Salud, you are modifying like the mother of it all. If you want something to work in the health system, you touch that law. And it's very difficult to touch that law. And that law has been modified to, so that the Ministry of Health does not promote formula. For example, we don't have a similar WIC program that provides formula for the breastfeeding mother or for the new mother. There's also modification on the bylaws by which employed women have the right to for 1 hour for pumping and a place to pump. And also, so that has been done in consultation with INSP researchers. And we're also at INSP in Mexico. We are part of an international group, which is NetCode, that it's formed by WHO and UNICEF, and there's 7 countries participating. Mexico is one of them, where we are planning to develop and deploy a strategy that has 2 objectives, the first of which is to monitor code violations, and the second is to evaluate the impact of such strategy. And this is a very interesting initiative that we just started, and we're very happy that this is happening. In funding, so far, there's these amendments to the law have not been accompanied by more resources, and it's particularly worrisome. But you know, the whole world and this region of the world, we're undergoing a very strong economic crisis, and there have been severe cuts all along the public services in Mexico, and so these strategies have not been funded. In terms of for education, our biggest university, the largest in Latin America, called Universidad Nacional Autónoma de México, UNAM, it has a medical school. It's the best medical school that we have, and they didn't have any breastfeeding. So we promoted the introduction of cases for students in the first and second grade, because we were talking with the dean of the physician, and he said, yes, of course. So we'll have pediatricians take the cases, and we said, no, we want everybody to know about breastfeeding, because it's not only pediatrician, it's obstetrics and gynecology, but it's also immunology, it's otorhinolaryngology, it's throat physicians, it's endocrinologists. So everybody should be aware, medical family doctors. So we have a foot in their programs, and we're growing, and we're very, very happy with it. We've also developed an e-course in Spanish, and this is a commercial that I'm doing to you. We developed an e-course that contains everything that WHO suggests or says that we need to do and we need to know on breastfeeding and infant feeding practices, and I only selected the breastfeeding part because there's a lot going on complementary feeding, but not on breastfeeding. So I selected that material for breastfeeding, and we were funded to do a project with our dean, our School of Public Health, and so we have technicians, web experts, and we have experts in education, and we have also a movie director that made the videos, and an artist taking pictures, and also an artist making draws for every module that we have. So we have original watercolors for every module, and this is a course that every module we have questions and answers that will be on the web. So when you want to take a test, you click, and then a random sample of the pool of tests of questions for each module will emerge, and then you have to answer them, and we have exercises all along. So at the end, when you finish and you approve, you get a B or a B plus or more. Then you have a diploma that you took that course, and it's going to have the credit value that offered by INSP. So we're going to launch it next month, and it's going to be free, and it's in Spanish, and it's the first free e-course WHO based in the world. So we're going to send it to Dr. Tarrant, so anybody that is interested is doing it. Now this is the promotion that Dr. Tarrant was talking about, because we have been so vocal about our breastfeeding rates, how we're lowering, how the industry is pushing for formula consumption, how the government, there's lack of leadership. We've been very active in that. There have been interviews in the newspaper and on television, and press conferences, and we have fora in the Congress. So we've been heard. So the government of the city of Mexico City decided to launch a breastfeeding promotion. But the physician who's in charge of the Ministry of Health in Mexico City decided to ask a cinematographer rather than to consult with academia or WHO or UNICEF, INSP. He decided to hire a cinematographer. So the cinematographer said, of course, we know how to do it. So what's the problem? It's the mothers that don't want to breastfeed. So the logo was, no le des la espalda, don't give your back to your baby, give the breast to your baby. As if the responsibility is of the mother and only the mother, and as if the mother is rejecting the baby. So that was a very strong idea in itself, not evidence-based, of course, as you know. But not only that, but the models that they placed were TV models, because they knew we have been very active at saying, exactly, doesn't she? I mean, piece of cake, right? And because we had been very active at saying we need actresses, we need high-profile women to promote breastfeeding, so that like the king in Thailand, and I mean, we really need important women to promote breastfeeding, because we respond to role models. So they said, well, this is an important woman. She's an actress. So these women, this ad was put forth, and many of them was put forth. The campaign probably lasted 2 or 3 days, because you can imagine all the criticism it received. Of course, we made a position letter and published it, and so it vanished from the spectacular. But it had, I mean, the backlash was not that bad at all. People started to talk about breastfeeding a lot, which didn't happen before, and also they knew they had to pay attention, that it's not that easy. And if you go, no le des la espalda, if you put that on the website, you're going to see several pictures and memes, or memes, I don't know how you say that. And but also there's been a few other very nice like that with women, that normal women, you know, normal women breastfeeding. I mean, with this, no le des la espalda, but not models. We've also, and INSP has been very vocal on saying that there's no money for breastfeeding in Mexico. We have not been funded for many years. We have a roster of projects that we have submitted for funding, and we have been rejected. So this year we received two lactation funding, one for Dr. Rivera and one for myself. And the Breastfeeding Week for Advocacy has been a tremendous forum for voicing, but we are lacking the effective coordination and leadership from the government. However, in last year, just prior to the week, Breastfeeding Week, we met and we supported the Ministry of Health to develop a lactation strategy and breastfeeding strategy. And if you read it, you would say, wow, isn't this a UNICEF program? It's really beautiful. But it hasn't been published. It hasn't been. But so we've made many advances. We don't know what's the impact of this. So breastfeeding should be the norm. We think that breastfeeding should be the norm. And Mexico has experienced dramatic reductions, but also we have had comprehensive advancements in many areas, and we don't know, although they have been somewhat weak, some others have been strong. We don't know the impact of those. And we have to make sure that a strong investment is made so that breastfeeding can be improved. So this is a breastfeeding baby, Mexican breastfeeding baby. Thank you.
Time for a few questions. Also for students and others, you can have lunch with her at 1 o'clock. That is upstairs too. There's more chances for questions too, but is there any questions that someone would ask? Yes.
I know that in Guatemala there are 5 regional maternal milk banks that women who can't or won't breastfeed can go to, or they're at hospitals, so that infants who are in the hospital and maybe their mothers can't stay and have to go back to their village. Does Mexico have a similar network of?
Yes, we're constructing milk banks, and it's a very good aid for moms who want to breastfeed but can't. Those patients with breast cancer or that are hospitalized. And we've been helped by Brazil. Brazil is the leading country in the world. They even export breast milk, can you imagine? They're fabulous. However, having said that, I consider that's the icing on the cake. It's very costly, it's very expensive. It makes the hospital and the government give a good face, but that's not what it needs to be in place for the mothers to breastfeed. But yes, to answer the question, yes, we're constructing. We do have several milk banks.
Well, again, that's one more question.
You mentioned that young mothers have the option to take 1 hour after the pump. Is that an unpaid?
No. It's paid, and it's nothing new. It's been in the law for years. In Mexico, we had a paid leave, maternity leave, for 3 months, a month and a half before, a month and a half after, where you receive 100% of your salary. And then while breastfeeding, you have 1 hour off. You can either take off to your home an hour earlier, or you can pump if you have a lactation station, and that's paid also. It's not-
Please come upstairs if you have more questions. And also, we have a very good lunch.
Sorry.